Great. Well, as we've been hearing a lot today so far, we are on the cusp of major transformation with the healthcare reimbursement in our country, moving from the fee-for-service to outcomes-based payment models. Congressional Budget Office has estimated Medicare expenses will expand from $632 million in 2015 to $1.1 trillion in 2024. And with that, the U.S. Department of Health and Human Services announced the goal that 90% of traditional Medicaid payments will be linked to quality or value by 2018. So CMS has really been leading the charge in this space with the HEDIS reporting measures for Medicare Advantage programs, for electronic clinical quality measure reporting as part of meaningful use, and now with the new macro legislation. What this panel today is really the first of 3 sessions that we will be focusing on quality reporting and measures. Today we're going to be focusing on the state of Michigan. Tomorrow there'll be a session looking at other initiatives across the country. And then Friday we'll do a deep dive in the quality workshop. So let me introduce today's panelists. We're going to start off with Jason Werner, who is the manager of Medicaid EHR Incentive Program at the Michigan Department of Health and Human Services. He's going to share with us the Michigan Automated Electronic Clinical Quality Measure Reporting Service for Medicaid Meaningful Use, which had a major event last week that he can share with us. Next will be Joe Neller, who's the director of Integrated Physician Advocacy for Michigan State Medical Society. And he's going to talk to us about an interesting, unique program in the state of Michigan where physicians and payers are sitting at the same table trying to figure out how to reduce the physician burden on reporting quality measures, on how we can increase the quality and quantity of the data that is being sent from providers to health plans for incentive programs, and then how we can use that data to help close some of those patient gaps of care. Finally, Ellen Bunting, she's manager at the Michigan Data Collaborative, will discuss quality reporting for the MyPIC, or Michigan Primary Care Transformation Project. And this MultiPayer initiative is the biggest patient-centered medical home, PCMH, initiative in the country, with over 1 million patients, over 350 practices, physician practices, and nearly 2,000 physicians participating. So there's a lot going on in our state regarding quality programs, and we appreciate folks on the panel taking time to share their experiences with us. The format that we're going to follow is we'll let each panelist present, and then we'll take questions at the end. So please join me in welcoming our panelists for today.
All right, well, thanks a lot for having me again, MiHIN team. I'll try to keep this brief because I know Joe likes to talk a lot, so keep it quick here. So like Rick said, I'll give you the perspective from the Medicaid perspective, specifically in regards to the Medicaid EHR Incentive Program and kind of what we got going on at the state in terms of clinical quality measures. So brief agenda here. So I'll start out with just giving a brief update on where we are at in terms of the Medicaid EHR Incentive Program. And then we'll start, like I said, we'll get into that deeper dive, where we're at currently in regards to clinical quality measures, and then where we're going, so the as-is and the to-be environment. All right, so where are we right now with the Medicaid EHR Incentive Program? So my first bullet here that I'd like to address, because I know when it first came out that the Medicaid, or the incentive program, Meaningful Use Incentive Program is dead. We were getting all sorts of questions coming into the state of Michigan, like, what's going on with the program? The program's going away. And so, no, it's not going away. So I just want to make that statement that Medicaid EHR Incentive Program is not dead, and it is not going away. In fact, we are open for business right now. We are actively collecting registrations for our 2016 program year. And actually, we opened up shop on that just last week on 6/1 of 2016. Shortly here, we will actually start with stage 3 of meaningful use. So the Medicaid program is moving forward with stage 3 of meaningful use. So we'll actually start those sessions here very shortly in terms of our design of how we're going to implement that in the state of Michigan, and we intend to roll that out in 2017 to give providers the option to submit attestations for stage 3 of meaningful use. I have to address the MIPS MACRA. I think every presentation thus far has mentioned that acronym. At this point, as it is, there will be, if providers are eligible for both Medicaid EHR incentive program as well as MIPS, at least the information that we have now, it'll be separate registration processes. We will obviously keep a very close tab from the Medicaid perspective on what MIPS and MACRA is going to end up being. I believe it's still in national proposal rulemaking process, and I think that's closed at the end of this month, I believe. So at this point, Medicaid doesn't really know how we're going to react to, the incentive program doesn't know how it's going to react to the MIPS MACRA. Obviously, we will keep a very close pulse on what's going on with that and react accordingly. All right, I'll throw a few numbers out here just to kind of give some context where we're at with the program. So with the program, it's eligible professionals and eligible hospitals for the incentive piece. Just throw a few numbers out. In terms of eligible professionals, we'll follow that column down first. As of 4/30/2016, we have about 5,900 providers that are actively participating. These are Michigan providers in the program. Of those 5,900, we have issued just over 9,700 total payments to them. In regards to how it breaks down, so the AIU, that stands for Adopt, Implement, and Upgrade. So essentially those are payments for folks just kind of getting their systems plugged in, kind of getting up and running. There's almost 5,700 of those payments. And then in regards to the meaningful use, so that's demonstration of that you're meaningfully using the system. And included in there is quality reporting. Of actually sending measures into the state of Michigan. There's been over 4,000 providers that we have information on. So altogether, on the professional side, there's been about $153 million of incentives that have gone out on the professional side. So if we focus on the hospital side next, we'll follow that column down. We have 117 hospitals in Michigan that are actively participating in the program. Of those 117 hospitals, we've issued just under 300 total payments, and the AIU to MU breakdown is 113 AIU payments have gone out the door, and 186 meaningful use payments have gone out the door. So altogether, it adds up to $157 million on the hospital side. So altogether, $310 million. So that's a huge investment in the state of Michigan, all going directly to health IT. So we think the program is definitely having a pretty significant impact in Michigan. All right, so let's get into the quality piece. This is what this panel is all about. So where are we at with quality reporting in Michigan? So there's actually 4 different mechanisms that are now, in terms of, for the incentive program, how we collect quality measures. 2 of them being still manual processes. So the first one is direct data entry into our EMIP system. So our EMIP system is basically our state level system that providers go in and register and attest for the program under. So we still allow folks to come in and just key their information into the system. We don't like that. We're trying to get away from that, but you know, it's baby steps of getting there. The second option is it's a little bit better than direct data entry. It's PDF, but it's still manual in nature. All right, the third one, and I actually got a slide to get a little bit more deep into this, is QRDA reporting. Basically, that's a standard transmission mechanism to electronically submit your files in, so folks don't have to enter information in. And so that's actually been live in Michigan since 2013. I think the biggest barrier to that is the EHR systems themselves weren't capable of doing that. They are now, as of stage 2 of meaningful use in the 2014 certification process. So we're hoping that process, we start to see an uptake in QRDA messages coming in. In what Rick was talking about, the big announcement, as of last week, we can actually receive these QRDA files via our HIE environment. So, and I'll get into that in a further slide. But it's coming through the MyHand Network, and it's a very cool thing that's available. So that's kind of where we're at right now in time. So that I just also want to mention that number 4 option, it's optional at this point. We're not forcing providers to do it. We're kind of in this phase of, let's make it available. Let's see if these messages can start flowing the way we hope to do it. So getting into the QRDA conversation. So QRDA is Quality Reporting Data Architecture. So hopefully this is an acronym that most of you have heard. So like I said, it's essentially a standard HL7 message, electronic message for clinical quality reporting. And it's actually broken down into two different categories. There's the category 1, which contains individual patient level data. And then there's a category 3, which is aggregate level data. So the state of Michigan is choosing to focus first on category 3 of the rolled up aggregate data, with a thought being of someday we'll move to category 1. When will that time be? We're not sure at this point. So now getting into our 2B environment, we want to continue with that HIE of getting them through the MyHand Network, and continuing to progress in that regard. Our goal at the state of Michigan is that we make that a requirement in 2017, but that will be contingent upon how our rollout period between now and the end of the year goes. And like I said, the secondary goal is to get to that category 1 reporting, and that is a to-be-determined date. Okay, so now let's get into what that HIE submission looks like coming through MyHIN. So one of the nice things we've been able to do is work with CMS on this to secure some funding through 9010 Health Information Technology funding. And they're fully supportive of this project that we call our Skimmer project. It's our Clinical Quality Measure Recovery and Repository System. So essentially how it works is you got eligible professionals and eligible hospitals, which they're required to submit quality measures to us, to the state of Michigan. And we've also built the infrastructure that moving forward that we can build this as a cost share model, that Medicaid will not be the only participant going forward, that we can cost share across initiatives. So you got these 3 different possible entities, and they can produce these QRDA files out of their electronic health record systems. Once the measures are submitted, and I should take a step back here, so they can either be submitted through one of our qualified organizations in the state of Michigan, or they can also be submitted via direct secure messaging. So there's a direct secure inbox that's also supported at MyHIN that will accept the messages as well. So the messages, they get submitted through MyHIN, through the Skimmer project, and they get checked for data quality. So they get checked against, that the most recent schema is used, that there's a valid MPI in the file, that there's no data integrity issues, and that's really nice because it catches all of that stuff at the front door before it gets pushed down into state systems. So we got a high level of assurance that if data is getting into our state data warehouse system, that it's of high integrity. So once all those checks are done, it gets pushed out into the edge systems. I also put PQRS on there as well, even though it's a federal system. MyHIN did go through the process of getting PQRS certified, so it really kind of supports that report once concept, that quality measures submission can fulfill state of Michigan requirements as well as federal requirements, and it all goes through one front door. So I believe this is my last slide, and this is kind of a slide in regards to why we think, well, obviously quality is very important for a lot of reasons, but why we think this particular model that we built is going to be successful. And the first bullet here is it's built on standards. So I think we're all in agreement here that you can't be successful without standards. So we are adopting the QRDA structure, which we think is pretty rock solid. The second bullet is we got a lot of smart people on this project, whether it's the MyHIN team, whether it's the CNSI team, whether it's the Optum team. They have all ingrained themselves in this QRDA structure. They've understood what it takes, and they're really ready and able to take us to the next level. So the third bullet is the one front door. I think that's really huge. Everything's coming through one point of entry. We're not maintaining separate entry points with everything, and we have that control of when things are coming through in regards to, like I'd mentioned before, we have high level assurance with data quality as things are coming through the door. and we're not maintaining, separate entry points. Fourth bullet is sustainability. Like I said, we're able to build a lot of this infrastructure on 90/10 federal dollars. We think going forward that as we introduce a cost share model, it's going to be very cost effective for other organizations, to get involved. We think there's opportunity for SIM to possibly join the Skimmer project, the Practice Transformation Network. We think there's possibilities there, other states for that matter. And then Joe will get into some of the PPQC activities where we think there's opportunity for Michigan State Medical Society to also come and be part of the project as well. And the final bullet is demonstrated value. I think the report once concept, it's one of those things where I think there's a desire within the provider community to, there's a lot of administrative burden to report various quality reporting mechanisms that, that takes a lot of time, it takes a lot of dollars, it takes a lot of energy, that if we can just push one file and it will fulfill all quality reporting, that's a win for everybody. And the final piece is you got clean data. We got a high level of assurance that clean data is coming through. So I think we're going to wait to the end for questions, but there's my contact information, our website, if you need any info. So I will turn things over to Joe at this point.
So just go forward.
Hopefully.
Great. Good afternoon. Thanks for having me here today to MiHIN, and I don't know how I ended up on a quality measures panel. Even though I've been working for physicians for over a decade, my background is actually as a lobbyist for various physician associations. So I have no idea what I'm doing up here with some experts in the quality space and speaking at a health IT conference. But I also couldn't have expected that Donald Trump would be the presumptive nominee of a major political party. So here we are. So Rick ran through a lot of what the PPQC effort over the last year. We started it June of last year, having some conversations on what the overarching goals of the initiative are, and those include, alignment of measurement, quality measures across sort of health plan incentive programs, streamlining a more efficient system for reporting of those measures to reduce administrative burden, and then sort of doing that in reverse in order to close gaps in care and improve patient outcomes. And that's a lot to get through in the 10 minutes that we have allotted. So I'm going to use this time to speak about how this initiative came about, and then Friday I'm going to have a little bit more time to get into the details of some of the specifics of those overarching goals. So one of my roles at the Michigan State Medical Society is to staff the Executive Council of Physician Organizations, and that is an entity designed to support physician organization leaders in their, support of practices in their local delivery area to transform care delivery and be successful under these new payment models. Currently, we have 12 partners listed on the screen here. This represents about 7,000 or actually more than 7,000 physicians. I say statewide, but we do not have the Upper Peninsula represented. That's something we would love to do, but I think geographically, for those that are from Michigan, the UP is kind of almost its own state at times, but we'd love to have them join these efforts, and we'd love to have more physician organizations join these efforts as well. But these are the people that really I go to, because as I mentioned, I'm not a quality expert. I don't have a clinical background, and I sort of work with them to help identify what we can do with the medical society to help physicians in practice. And one thing that I would note about these partners, our current partners, is a lot of these groups are representing high numbers of independent private practice. And that's not to say that we aren't also engaging large hospital or health systems. We certainly are, and we'd love to bring them into this discussion more than they have been over the past year. But I think that there are some unique challenges when you're talking about independent physician organization groups in terms of the number of vendor platforms, EMR vendor platforms that they're dealing with and trying to aggregate data from and integrate, in addition to the number of practices that still are using paper records or fax machines and the challenges that that present. In addition to the tremendous expertise and knowledge that these groups provide, I also have to acknowledge one of my colleagues at MSMS, Dara Barrera, who's a HIMSS board member. She helps me figure a lot of this stuff out, and then our collaboration with MiHIN, Rick Wilkening and Bo Bernacki in particular have been tremendous resources. So as I mentioned, the Executive Council is a collaboration to support PO leaders as they help their physicians obtain, I guess what is now being more frequently called the quadruple aim of higher quality, lower costs, and enhanced clinical experience for both the patient and the physician. And that physician satisfaction piece is sort of the quadruple or the fourth leg of that stool that used to be a three-legged stool. We came to the PPQC effort by conducting a strategic planning survey. I should have mentioned the Executive Council is an initiative we started sort of late 2014 with those groups. So as we formed this entity, we went through a strategic planning process, and the two top priorities were quality measure alignment across health plans and HIT, HIE infrastructure, and in particular interfaces. So in our continued deep dive into how do we go about tackling those top priorities, we asked the PO leaders on the Executive Council to submit an open-ended measure survey about what they would which measures they would prioritize for alignment discussions. And that resulted in about 35 to 45 common measures. In an attempt to tackle the HIT, HIE interface question or infrastructure frustrations, we actually invited Tim Pletcher, the executive director of MiHIN, to come to our meeting in March of last year and give a presentation just generally on the status of health information, infrastructure, and data exchange in the state of Michigan. As part of his presentation, he actually referenced the Skimmer project that Jason just gave his presentation on. And we began a discussion about how we might begin to leverage that and expand it to this report once concept, so physician organizations don't have to have a one-to-one data exchange with every payer that they might participate with. So how do we expand it so it's beyond just Medicaid and includes PQRS, which Jason referenced as well, but also the commercial payers and their incentive programs in the state. And that was sort of the impetus of what became the Physician Payer Quality Collaborative, or PPQC, and we might need to think of a catchier acronym, but that's the best we came up with. So in June, following that March presentation, we invited the health plans, the major health plans in the state, to attend a meeting, and we talked about physician organizations and the challenges they're having sort of reporting their quality performance under the current system, and how administratively burdensome it is for these leaders and their practices. The health plans were sympathetic to that. They also shared their frustrations of trying to extract clinical supplemental data in particular from, I would say, I guess, non-sort of large enterprise deployment vendor platforms like the Epics and the Cerners of the world. So we asked, following that June conversation, we asked the health plans to go through the same survey process that the POs did and submit an open-ended survey of quality measures that they would like to see alignment discussions on. We took all of those data sets that were submitted, and Bo Bernacki in particular helped me crosswalk those, and it resulted in 9 common measures across all of the data submissions from both the physician organization community and the health plan community. 7 of the 9, Bo had also done some research looking at some federal and state quality measure programs like PQRS, meaningful use, HEDIS, et cetera, and he had found that there were 9 measures that sort of naturally overlapped. 7 of those were common with our PPQC measures. We had another 15 measures for a total of 24 that were on the majority of the data set submitted. So we started with a foundation of 24 quality measures identified as priority measures from both the physicians in the state and the major health plans in the state. And that sort of serves as our foundation for a lot of these discussions in PPQC. And these are the 24 measures plus 3 additional measures that emerged when we were talking with some of the state Medicaid folks who identified 3 measures that CMS were interested in particular: tobacco use and cessation, antidepressant screening, and antidepressant medication management. So what was 24 became 27. And I think in some conversations, we actually have 31 because we have some hospital-specific utilization measures around ED use, readmission rates, and a couple others specific to SIM. So we're going through a pilot process on those quality measures right now and the sort of technical infrastructure on how those get reported. Again, focusing on this concept of report once. We have not asked any of the physician organizations or the health plans to discontinue their current one-to-one data exchange, but we are testing sort of submission, not sort of, it is submission of a single all-payer, all-patient data file on these 27 core quality measures. And MiHIN is helping, similar to the Skimmer project, they're helping route that to the appropriate endpoint. And I will talk more in detail around sort of the format standards and transport mechanisms and the gaps in care closure discussions on Friday. But that is a very quick overview of a year's worth of work and numerous meetings and hundreds of hours of work on both the physician side and the health plan side and MiHIN side in particular. So I think with that, I'm going to give it over to Ellen.
Good afternoon. I'm Ellen Bunting. It's nice to be here with you. Thanks to MiHIN for inviting me. Thanks, Rick. The 2 fellows before me kindly shortened their talks and granted me 5 extra minutes. I hope those 5 minutes are worth your while. We're going to be talking kind of in a broader sense about what quality measures are for and how we use them at the Michigan Data Collaborative. What's unique about the database that we've built and the measures that we create is that it's in a multi-payer environment. This has come about as a result of some initiatives in the state of Michigan. MyPIC is a large part of that, and so we'll be talking about the MyPIC program that's been mentioned a little bit earlier today. In general, quality improvement and what that means for measurement and how you set goals and measure in a multi-payer environment. Aligning HEDIS measures is important. We talk about trying to get to a standard set. Very often when we're talking about measures created with claims and even measures created with claims and EHR data, we're talking about a measure that was originally vetted through HEDIS. So I'm going to talk a bit about HEDIS and how you have to work with those in the multi-payer environment. And then a little bit about how having all payers in your data and creating measures for all payers changes the perspective. The MyPIC project is vast. It covers the entire state. It's about 350 practices, 1,800 physicians. At its core, it's demonstrating the value of the PCMH model. And importantly, the data that's gathered and results from having all of those physicians and practices working on performance and quality measurement, that data comes to us at the MDC in multi-payer formats. So we'll talk a little bit about how we manage that data. Just a refresher on PCMH, we talk about these acronyms like everybody knows what it is. And so the patient-centered medical home has a few key elements. I've listed them here, but most importantly for the PIC project and for a lot of the initiatives that we're talking about today, coordination of care is the key to making sure that all of the elements work. And the PIC model in particular has focused on empowering and paying for care managers embedded in these practices that can help coordinate all the important functions of the healthcare entity. And for us, we really feel that data is really at its highest and best used for learning and finding variation, and then not penalizing those that are not the high performers, but rather modeling what the high performers are doing. And so your goal setting and in a primary care really needs all information from all payers, not just information by healthcare plan. So we've heard today a lot about payment models, delivery models. They're coming, they're here, and in the middle of all that are performance measures that practices, physicians, healthcare entities are all being measured on. And these performance measures are important not just to the health of the patients, to measure how their well-being and to improve their health care, but they're also important to the financial well-being of practices and more so into the future. So clinical and claims data, I like to say, serve many masters. It's not just a matter of seeing how you're doing with one particular measure and how that population is doing. It's also how is your entire healthcare entity doing in that domain. And so what we found when we were starting to gather all the data from the 5 payers is that the measure set that you'd want to use, HEDIS measures in particular, are designed to measure populations within a health plan, in particular within a commercial health plan. So what we were doing is gathering commercial, Medicaid, Medicare claims all together, putting them in a common data format, all payer claims data format, sticking it in a great big database, and then trying to pull out measures that were specified by plan instead of across plans. So what we found is that HEDIS measures will work. You don't need different measures. You don't need to create your own measures, but you do need to work with a different tool, or just modify the tool, I should say. You don't need a whole new tool. You just need to modify the tool to make it work. And so I'll talk just a little bit about how we did that, and I promise this will be the most technical slide that you have to sit through. But it's important to know what it is that you run into when you're looking at your measures in a multi-payer environment. So I put this graphic up there. I stole it from NCQA so that we could see that these HEDIS measures are well vetted. They have a beginning and life cycle. They go through public comment, and when they are no longer useful, they are determined to be retired. So it's a good set to start with. However, in the multi-payer environment, you're going to read the specifications and understand that they are looking for ages that are appropriate to the health plan. So you'll have to modify based on age. The reporting period is always a calendar year. When you're monitoring your health care, the health care of your patients and your practice, you're not just looking at the calendar year, you're looking from year to year. You might be looking at a year's worth of data, but it's from half year or bi-quarterly. So it's important to understand that you've got to reapply the measures to the reporting period that you're looking at. And people are in multiple plans. They don't just stay in one plan during any reporting period or during any year. So what we wanted to do was to include everybody in the healthcare environment and call people insured if they had 11 or 12 months of enrollment. Oftentimes, continuous enrollment really just means from January to December with maybe one gap. But if you're looking at your entire panel of patients, you may find that patients are in a plan in the beginning of the year and then in a different plan at the end of the year. And if you are looking at the continuous enrollment very strictly within one plan, a lot of your patients will drop out of the measures. You won't be measuring your entire population. So what we do is we look at continuous enrollment across plans, not just plan by plan. And when I was talking about the reporting periods, that also becomes very important in this notion of continuous enrollment, because depending on where you cut the data, you will get a patient who will belong to a measure based on which plan they were with in April, or perhaps in March. You're not always just looking from January to December. So I've been talking about the MultiPayer Database, and I thought that I should put this slide up there because it kind of gives you a good visual of what that is very simply. There's about 40 physician organizations that are participating. From them, we get EHR data. We have 5 payers that are participating. From them, we get claims data. We put them together, and then in some cases, we create ECQMs that for us mean the numerator is made from the electronic medical record, the denominator is made from claims data, eligibility data in particular, or it can mean that it's a simple HEDIS measure that's been supplemented with the EHR data. And we've gone through a lot of testing and false starts and trying to get this data in and making sure that it is what we need from the medical records. And so far, it's been working pretty well. And I know that Joe is also talking about the same format, is trying to bring data directly from the POs up to the state, but in that case, all payer as well. So a couple of things that I wanted to talk about that were clearly a part of making it a successful endeavor is that you really want to use all data, if possible, to create these measures. What we found was when we created measures strictly from claims, we were getting about a 3%, sometimes 8%, depending on the measure, jump if we included supplemental EHR data. So that would be tests that perhaps were never billed for some reason or another, but were in the medical record. So the claims data is pretty good. You can get pretty far with that. And for the most part, we're averaging about 3 to 4% more per measure when we include the supplemental data. But to get the whole picture of the patient's population and population health, you really want to include both. And We'll be talking in much more detail later about MiHIN's effort for the Common Key service. That is absolutely essential. You can imagine when you have patients that are crossing plans, and you're bringing in clinical data for this patient and claims data for that same patient, how do you even know they're the same patient? We've instituted our own master patient ID, but it would be so lovely to have a common key already coming across on the record that you would be able to link. So I'd have to say that's absolutely essential. And then you really want to identify the denominator by population, regardless of payer. A patient doesn't walk into a practice with a Medicare sign on their forehead. They are your patient who has diabetes. And when you want to measure how your patients are doing at your practice, you want to know how your patients with diabetes are doing. You don't want to know how the Medicare patients are doing and how the commercial patients are doing. You want to include them all in the denominator and then figure out how your measures are going as a result of a more inclusive and wide-ranging perspective. I stole this slide from the Institute for Healthcare Improvement. And I wanted to put this in here because I think it's important not to be discouraged if you don't feel like you're getting the data you want or you're not able to do what you want with the data, that a lot of people are just in the reporting what happened. But importantly, monitoring what is happening now is very good. And that doesn't mean that you have to have what happened last month. You have to know what happened recently and how that trend is going and what you can do to bend that trend or encourage that trend. The data should be recent, but it does not have to be last month's data. You can still make a lot of progress understanding how your populations are doing by looking at data trends over time. And for this conference, I think what's important is the end of the arrow, the prediction and the prescription. This is where we're going when we really have machine learning and learning health systems, and we're able to see who is going to need healthcare next. And you can do that with your data. There's analytics and tools out there that are available to do that. That's I think, pushing the envelope at this point, but a lot of people are doing it. And I thought that I would end the talk here with something that is encouraging. I just heard this on the news recently, and I thought it was a very apt metaphor for what we're trying to do in healthcare. Change is hard, but it's not impossible. And in the 80s, the Carter Center set about trying to completely eradicate the guinea worm. And it sounds like a really big task, and if you understand what it is that the raw materials they had to work with, it was very minimal. But they said, okay, this is a disease that no one is concentrating on. It comes from water supplies, primarily in Africa. Let's do something about it. And that was in 1986. Well, just this year, they reported that in 2015, they went from an estimated 3.5 million cases in 1986 to 22 cases. And they didn't do this with a vaccine or with a novel treatment or with medicine or pharma. They did this entirely by changing behavior. And in order to change behavior, they had to go into war zones. They had to go to 300,000 villages. They had to change the behavior of people who had a very painful disease, especially when the guinea worm would start to reemerge. It was very common for the people infected to then go soak their foot or their arm or wherever this worm was coming from right in the water supply, and thus starting the cycle all over again. So they had to change the behavior of people who were suffering very mightily from getting relief. And they were able to do this. They did it not only with, by changing people's habits of using their water supply, but also about teaching them how to purify it and handing out filters that they were then taught to use. So I think when we talk about how hard it is to get our patients to eat better or move more, or how to change workflows in order to get our IT in a way that's usable, we know it's hard, but it's not impossible. And there's many people out there that are facing many obstacles that are able to do a lot of change. And I think what's kind of ironic about this example is that it's been about 30 years for this to happen, and I think that healthcare has been kind of working in this domain for about 30 years. So, you know, maybe we'll be getting there soon. Jimmy Carter is a pretty great person. I think that he's very vital. He just vanquished brain cancer, for goodness sake. And I do believe that the last guinea worm will die before President Carter. So thank you.
All right, so we do have a few minutes for some questions.
First of all, I want to thank all of you. I think that this work that you're doing is about the most exciting and inspiring that we've heard all day. And this idea of getting information, clinical information out of the EMRs through a coherent process at MyHand and distributing it to the people who need it is just so incredible. I'd wonder if you could each comment on where you think we should be in 3 to 5 years in terms of this entire challenge. We know that the federal government's program for reporting quality information is growing by leaps and bounds in the MIPS program. It's expanding wildly in the commercial payers. How do you see this evolving to have a coherent, systematic way of pulling this information forward and reporting it to meet these various needs?
Thanks, Dr. Simmer. Is this on? Yeah. So I am operating in the world of claims plus EHR data, and I like that place. I think that you get a lot of value from claims, and a lot of the electronic reporting, like the PQRS measures, are entirely electronic data. So from my point of view, I would love to see an all-payer claims database in the state of Michigan that would allow the kind of deep analysis that can be done with claims data. And I would see a partnership with an organization like MiHIN that would be then bringing EMR data to the all-payer claims database in order to supplement the measures. Because from what we found in working with this data is the claims data gets you almost there, and the EMR data kind of puts you over the top to give you the true view of the population.
So I think that was an excellent answer, and I don't know how much more I have to add. If I knew where we'd be in 3 to 5 years, everyone in the room would be working for me already. But I think from a payment standpoint, what physicians are looking for is some consistency, you know, leaving the IT aspects aside. They're looking for consistency on what quality is. And I think the challenge is, you know, health plans always think that they have some special sauce, right? And that's one of the things that I've been learning through this PPQC process over the last year. I always, you know, HEDIS is sort of the national standard, but what I've been learning is, you know, health plans always think that they have that special deviation that's gonna, you know, really set them apart from their competitors. And I don't know if that's true or not, but I think, you know, physicians are overwhelmed with everything they're being asked to do. And I understand as a consumer of healthcare, you know, it's still, in 2016, it's amazing the amount of effort that's going into automate an industry when I can bank from my phone anywhere in the world. But I think the more that we can do to sort of align payment and really define what quality is across health plans, so as Ellen said, physicians don't have to chase sort of, what health plan the patients are associated with, and the check boxes and the hoops and everything that they have to jump through to be considered high quality by that specific payer, and really define quality across all payers and consistently is somewhere that we definitely need to go. And I think Ellen's answer is going to play a major role, and that IT infrastructure will be a major tool, obviously, in helping us get there.
Yeah, from the Medicaid perspective, like I kind of mentioned in my presentation, QRDA Category 1, that's the holy grail. So the 3 to 5 year, that's where we want to be. I think it's going to require, pushing the EHR vendors, to get their products to actually be able to output that. We're getting close with QRDA 3s. I think most vendors, excuse me, that we talk to can do it. We are running into some challenges. There's some different schema versions of the QRDA 3 that are out there. There's some files that don't contain MPI numbers. All that stuff is critical that we get that all standardized and that we can get those consistently being produced out of EHR systems. So QRDA Category 1, holy grail for the state of Michigan.
I think we're all going to kind of our wheelhouses, so I'll talk on the technology side. I think what we would love to see is the movement towards a real-time flow of this information, the QRDA Category 1s automatically being accumulated and automatically landing where they need to land so that we can get that gaps in care information directly back to those physicians. And also when a new patient is scheduled, a patient is scheduled for a visit, that triggers a response from the payer to notify that physician as they're prepping for the patient, that either the next day or that day, that these are gaps you need to take care of while the patient's on the visit. I think the fire team or the fire resource folks, I think that's an interesting evolution as well, trying to make it light and not even evolving from the QRDA format. So maybe 3 years is aggressive, maybe 5 years is where we could be. So I thank you. Great question. Obviously, we all spent some time answering that. I think we actually spent so much time we ran out of time for other questions. Yes, Tim?
Can I ask my question?
Sure. You're my boss's boss. You can ask as many questions as you want.
I want to actually ask the audience a question. How many people here have been involved in this sort of quality reporting space? Just raise your hand real quickly and hold your hand up for a second. Okay. How many of you are intimately familiar with Category 1 QRDA format? Okay, so it's a short list of folks that are kind of looking at this electronic clinical quality measure space, even for the folks who've been in the business for a long time. So I think there's some learning opportunity for Jason's sort of 3-year goal. Thanks.
Thank you.
Nice job.